Good morning, friends, all those from India and who got up early, and good evening to all my friends in United States. Welcome to this 87th episode of the continuing medical education programs, the webinars that are being conducted by Andhra Medical College uninterruptedly. And thanks to Dr. Kulkarni for coming on board again. So he has been very kind all through, and he keeps on updating our knowledge every fortnight or every month. And we look forward for many such sessions in future as well. And I wish to thank Dr. Kairam for moderating this particular session. And it's important for us to know about what's currently going on around the world and the current strategies and the newer variants that we are dealing with and the variants that are going to come as well. And Dr. Sridhar Chilumari has logged in, and I'm very eager to have his comments towards the end of the session to know as to what's going to happen in India over a period of time. We have many other professors and Dr. Prem Kumar and others who will be joining us to make some contributions. Dr. Kairam, you may start the proceedings after introducing Dr. Kulkarni.
Yeah, actually, since he has been so kind to come on and talk to us twice already in the past, I have to come to depend on him to address this group on short notice. And Dr. Kulkarni is on the faculty at Baylor College of Medicine. He was introduced to us by Dr. Kalpalata Guntupalli, and he has become a reliable source of information. Today, when I sent this announcement to other groups other than just Mrna family, Andhra Medical College alumni family, I put in an extra couple of sentences saying that tonight you will hear from my most favorite speaker because he pays so much attention to evidence-based medicine and is able to quote firmly material behind his statements, recommendations, or slides, and practically everything he says can be backed up by published evidence in peer-reviewed journals. For that, I have come to recognize him as a reliable source, and he's been always very accommodating and quick response, and therefore I'm very happy to present Dr. Prateek Kulkarni. There you are, sir. Go ahead.
Thank you very much, Dr. Kairam, and thank you again to you and Dr. Sudhakar and all of my now virtual friends at Andhra Medical College, including faculty, others, alumni, etc. It's been an honor and a privilege to be able to speak with all of you on a routine basis about COVID, which has been an interest for me clinically, but also since my parents are from India as well. I was actually born in Pune, in Maharashtra. So I feel some emotional connection still. And I hope this is some way I can contribute back to the my home country. So I hope this is helpful. And thank you again to Dr. Kairam and Dr. Sudhakar for the kind invitation as well. So the subject of this evening's presentation is going to be an update on COVID-19, epidemiology, vaccines, Delta variant, and treatment. And as Dr. Kairam mentioned, I'm a faculty at Baylor College of Medicine, which is a medical school in Houston, Texas. And good morning again to all of you. I know it's very early in India right now, so thank you so much for waking up so early to join us. Here are my disclosures. Just by way of acknowledging, I have a few research grants, and I also receive fees for speaking and consulting from various companies. The objectives of this presentation are to understand the current epidemiological trends in COVID-19 nationally and internationally. Describe vaccine effectiveness in the era of the Delta variant, which has been a major source of concern here in the United States, which with all kinds of talks about boosters and the rest of it. I want to go through some of the actual data in some detail. And finally, I want to describe and review the clinical presentation of COVID once more. I know we've done that in the past. And also updated recommendations regarding treatment. There have been actually a number of new trials that have come out in the last few months, which may be helpful and may inform how we should be treating patients right now, and potentially how things will change going forward in terms of actually treating patients with COVID-19. As I said, there have been a few different trials that have come, so I hope to briefly review them this evening or this morning. Let's start with epidemiological trends. Here's a graph of the number of new daily cases of COVID-19 around the world over the last several months. As you see, the number of cases has been going up, down with every wave. So here we are in early September 2021, and we are right around 600,000 cases per day still around the world. And as you see, it's just going up and down, up and down. There's no clear trajectory over the course of last 1 year. Here's the situation in the United States right now. I realize I'm talking to an audience in India, but just by way of interest, we had a big wave around December, January. Then we started aggressively vaccinating. Numbers came way down, and we thought, okay, everything is better. Everyone was feeling very comfortable. We thought things were improving. And then really in the month of July with the Delta variant, which actually was in India, of course, before it was in the United States, things really shot up quite a bit. And there are still now around 175,000 cases per day in the United States. And unfortunately, our deaths in the United States have also started to go up. Usually deaths lag by a couple of weeks after the cases go up. And so we're starting to see that rise here in the United States, which is unfortunate. This is the situation in India. Of course, you all are experiencing it firsthand, but just to show how it looks graphically. As you see, the wave that you all experienced in May and June was very bad, and the numbers were quite drastic, and up to about almost 400,000 cases per day. And probably this is less less than the real count, because some people probably weren't getting tested. And in fact were positive. So the number was probably even higher than this. Thankfully, the numbers have since come down. And I know India has really been ramping up the vaccinations recently, which is great. Unfortunately, there was a concomitant rise in deaths as well in India, which is very sad. And in fact, I don't mind sharing with you, one of my own aunts who lived in Pune, she actually passed away as a result of COVID back in June during this massive spike. So even I was personally affected by this tragedy that occurred at the time. Thankfully, those numbers have started to come down, and hopefully they'll stay down. So we'll have to see what happens. But so far, it looks like things are steady in India, which is good. So let's shift gears now to vaccines. So I realize the vaccines in India are different. You all predominantly have Covishield and Covaxin. I know that, but just to show you sort of what's happening here in the United States in terms of the current status of vaccines and what's being recommended currently is the following. We have Pfizer, which is an mRNA vaccine. And the thing that changed was that a few weeks ago, Pfizer actually received full approval from the US Food and Drug Administration for people 16 years of age and older. And why that's different is because back in December, they only had what's called emergency use authorization. The difference between emergency use authorization and full approval is that full approval looks at data for 6 months period of time. What they're really checking is not only is the vaccine effective, but in addition, is it also safe for 6 months? So that's the difference between emergency use and full approval, is they evaluate the vaccine for a longer period of time. So Pfizer has full approval since late August. The second vaccine that we have is Moderna, which is also an mRNA vaccine, and it still is only under emergency use authorization for people above the age of 18. And then finally, we have Johnson & Johnson vaccine, which is an adenovirus vector vaccine. And it has emergency use authorization for people above the age of 18. And of course, Covishield is a version of AstraZeneca vaccine, which is also an adenovirus vector vaccine. So we have a version of that in the United States as well. People often ask me a lot of questions about booster doses, at least here in the United States. And currently, as of right now, September 12, 2021, currently a booster dose in the United States is only recommended for patients with moderate to severe immunocompromised state. And what that means is, not to go too deep into detail, but what it generally means is people receiving active chemotherapy, people who have undergone organ or stem cell transplant, people with untreated HIV/AIDS infection, or people receiving a number of immunomodulatory biologic agents or immunosuppressive agents for rheumatologic conditions and things like that. So you really have to be pretty immunocompromised to qualify for a booster right now. And as I mentioned, there's currently no booster recommended for other populations, including even older people. Now, to my knowledge, one of the only countries in the world that is currently recommended a booster for anybody is Israel. Israel has recommended a booster for people above the age of 60. And in fact, I think they have now since extended that to all adults. But they're one of the few who has done that. I don't think many places have done that, including the United States. Currently, it hasn't been authorized. Just for your information, in about 1 week, FDA is planning to meet on 17th September to discuss boosters for the general population. We'll see what recommendation comes after that. But currently, boosters are only recommended for patients with moderate to severe immunocompromised state. And actually, before we started the talk, Dr. Sudhakar and Dr. Kairam and I were discussing a little bit about vaccinations. And at the top here is what's going on in the United States. And as of yesterday, in the United States, about 54% of the population had been fully vaccinated, meaning they've received their full 2 doses. And almost 64% of the population had received 1 dose. Compare that to India, which I want to just take a minute and say India has done a tremendous job vaccinating its population. I mean, they are really doing outstanding. And if you look, it's really gone up dramatically. And so as of yesterday, almost 15% of the population had been fully vaccinated, and almost, or right around 40% of the population had received 1 dose of a vaccine, which, if you compare to the United States, is not much different by 20%. And our population is, slightly less than 400 million, and India's population is more than 1 billion. So India is doing a tremendous job vaccinating its population right now. And I think that is something to celebrate and congratulate all of you for doing such an excellent job in India right now, vaccinating the population. I want to take just one slide to talk about a pediatric vaccine. I get this question all the time because in the United States right now, we have no vaccine authorized for children younger than age 12. And so people frequently ask me, what should be done? And there was a story that ran towards the end of August in the United States. And the director of our NIH, National Institutes for Health, Dr. Francis Collins, made a comment. He said, probably a vaccine for children is not likely to be approved or authorized until the end of the year, 2021. Maybe it will come in October, November, I'm not sure, but this was his comment. So everybody got very worried about this. And many people started asking, well, should we just take the Pfizer and start giving it to 10-year-olds or 9-year-olds or 11-year-olds or something like that? And very importantly, about 2 weeks ago, the American Academy of Pediatrics was very clear in their recommendation, which was that they cautioned against off-label use of COVID-19 vaccines in children under the age of 12. And so many people may or may not know, I myself have a daughter who is in this age category, meaning she's less than age 12. And I plan to follow this guidance for her. And until a vaccine is authorized for her age group, I won't be planning to give her one. But I get this question all the time. Many of you may be either seeing pediatric patients or you may have children of your own. But this was sort of the statement that came from the American Academy of Pediatrics. And I think it's probably a good idea. One of the reasons is that some of the vaccines that are being evaluated in children right now are at a very different dosage. So some of them are half the dose or even less than that. So I think we have to be a little bit careful giving a full dose to an 8-year-old child, for example. So here's the question that everyone has been asking me for the last 1 month in the United States, because there's been a lot of worry about breakthrough infections, meaning people who get an infection after they've been vaccinated. And so there was a lot of fear in the United States that vaccines are not working or somehow creating variants, or some people were saying, well, why should I even bother to get vaccinated because I'm going to get infection anyway. So I think, unfortunately, some of that news has been out there. And so people got, some part of the population got the idea that vaccines are not working. But let me show you some of the actual data to show what's actually happening with regards to vaccines and their effectiveness, even in the era of Delta. First, let's talk about breakthrough infections. That's a term that we use here in the United States. I don't know how frequently it's used in India, but we talk about it all the time in the United States. The definition of a breakthrough infection is a SARS-CoV-2 infection that occurs in somebody a minimum of at least 2 weeks after their final COVID vaccine. So once somebody has gotten their full COVID vaccine series, more than 2 weeks after that, if they get a SARS-CoV-2 infection, that's considered a breakthrough infection because it happened to them even after having been vaccinated. But the critical point is that not all infections are the same. So somebody could have an entirely asymptomatic SARS-CoV-2 infection. They could have a very mild infection and recover at home with no problem, or they could have a severe infection and end up in the hospital or have mortality as a result of COVID. Let me just say that even before the vaccines came, approximately 1/3 of all SARS-CoV-2 infections were entirely asymptomatic, meaning the patients didn't even feel that they had an infection. They had no symptoms. And that was before the vaccines. After the vaccines, that proportion of infections which have been entirely asymptomatic has gone up. It's probably higher than 1/3 now. And then the proportion of infections that are mild has also gone up. So it's true that breakthrough infections have been going up because of Delta variant. But the important thing is that the percentage of patients who have a severe infection and end up in the hospital or die as a result of COVID still is quite small. And let me show you the data to support that. So as I say, there's multiple lines of evidence that support continued robust protection against hospitalization and death, not necessarily mild infection, but against hospitalization and death. So there are four pieces of information I'll show you. One was an outbreak of COVID-19 amongst vaccinated patients in Massachusetts. Another one is an article from New York State. Another one is an article from Los Angeles County in California. And finally, I'll show you some national data on breakthrough infections in the United States. So this was published in the Morbidity and Mortality Weekly Report, which is a publication from the US CDC, Centers for Disease Control and Prevention. And it describes an outbreak of COVID amongst fully vaccinated people in Massachusetts. This is at the beginning of July. So let me show you exactly what they found. So this is a summary of the Massachusetts outbreak. So at the beginning of July, there were multiple summer events and large public gatherings in Massachusetts. It attracted thousands of tourists from around the United States. There were 469 cases of COVID, and the background vaccination rate was pretty high. It was a younger population. The median age was 40. About 75% of cases, 346 cases, occurred amongst fully vaccinated individuals, meaning 3/4 of the cases occurred in people who had been vaccinated. That's true. 90% of these cases were due to Delta variant. And 80% of the patients did feel some symptoms. They were symptomatic. However, only 1% of those 346 patients were hospitalized. And there were 0 deaths in that group as well. So the point is that even though there were a large number of infections that occurred in people who were fully vaccinated, The number who was hospitalized were 4, and the number who died was 0. So that suggests still very robust protection from death and hospitalizations due to the vaccine. This is another study from the middle of August, also published in MMWR from New York State. So this is a summary of their data. From May 3rd to July 25th, there were about 10,000 new cases of COVID-19. And I'll add, in the United States, Delta was going up dramatically during July. That's really when we, United States got hit hard with Delta. In India, it was probably April, May, maybe even a little bit before. But in US, it was July. And there were about 1,300 new COVID-19 related hospitalizations during these 3 months. The overall age-adjusted vaccine effectiveness against new COVID-19 cases went down from 90% to 80%. So that's true. Vaccine effectiveness against any infections due to COVID, it did go down from 90% to 80%. So there was a decrease. That is a true statement. However, vaccine effectiveness against hospitalization was stable around 90 to 95%. So the important thing is when people talk about vaccine effectiveness, it's very important to ask the next question should be, are we talking about effectiveness against any infection? Are we talking about effectiveness against mild infection? Are we talking about effectiveness against hospitalization? Or are we talking about effectiveness against death? Because all of those numbers will be different. And the vaccine effectiveness will go up as you talk about severity, hospitalization, and death. The vaccines are more and more effective as you talk about increasing severity of disease. So that's very, very important. It is true the effectiveness has gone down against mild infection, but it hasn't yet necessarily shown clearly that it's going down against severe infection. Finally, there was another MMWR article published at the end of August from Los Angeles County in California. And here's a summary of their data. From the same period of time, May, June, July, there were 43,000 cases of COVID in Los Angeles. 25% of cases occurred in fully vaccinated people. However, amongst those fully vaccinated people, only 1% of fully vaccinated people were admitted to the hospital after their positive test, compared to 4.2% of unvaccinated patients who were admitted to the hospital. And this graph is very nice. It tells a lot of information. At the top, it says age-adjusted rolling 7-day hospitalization rates. And this top line right here is unvaccinated patients. And you can clearly see that from May to July, the number of unvaccinated patients who were being admitted to the hospital because of COVID was going up. It was clearly rising. This is number of hospitalizations per 100,000 in the population. So this was clearly going up. If you look at the bottom blue solid line, these are patients who are fully vaccinated. And as you can see, from May to July, yes, there was a little bit of increase, that's true, but very small. And the difference between unvaccinated and vaccinated patients was huge. So the point is that the main risk for ending up in the hospital because of COVID in May, June, July in Los Angeles was because of vaccination status. And people who were fully vaccinated really were not ending up in the hospital much. So I think this graph is very telling. I think it's, and in fact, very reassuring as well. And so based on this study, CDC created this infographic, which says a July 2021 study of Los Angeles County found that unvaccinated patients have 5 times more infection due to SARS-CoV-2 than fully vaccinated patients. And unvaccinated patients have almost 30 times more COVID-related hospitalizations than fully vaccinated individuals. So still, the main protective factor from staying out of the hospital from COVID was being vaccinated. And finally, here's national data on breakthrough infections from CDC. So as of August 16th, 1 month ago in the US, more than 168 million people in the US had been fully vaccinated against COVID. Until that period of time, there were about 1,800 deaths due to COVID in people who had been fully vaccinated. So the number is not 0, but it's only 1,800, and there were about 8,000 patients who were hospitalized due to COVID, even if they were fully vaccinated. So if you just do some quick math, that means that 0.005% of fully vaccinated patients have been hospitalized due to COVID in the United States, and 0.001% of fully vaccinated patients have died due to COVID in the United States. Now, these data are incomplete, but they give you a general snapshot of what is going on. And so the main point is that, again, vaccination still remains our main protective factor. It's not 100% against hospitalization and death, but it's very, very good. I mean, it's still in 90-95% range for hospitalization and even higher for death. Finally, people often ask me this question when we talk about COVID-19 cases. They ask me how many cases, what percentage of COVID cases are occurring amongst people who are fully vaccinated? Because that seems like an important thing to know. But my view is that that is a slightly incomplete metric. It doesn't tell the full story and can be misleading. Let me explain why. Consider this scenario. You have a city of 100,000 people, 1 lakh. The vaccination rate in that city is 100%. Everybody is vaccinated. And let's pretend 1,000 people get COVID. 35 people get hospitalized and 2 people die. In this scenario, the percentage of cases of COVID that occurred amongst fully vaccinated individuals is 100%, because by definition, everybody is vaccinated. So any case that occurs is going to be in a vaccinated person. Consider a second scenario. Same city, 100,000 people, 1 lakh. 50% vaccination rate. So only half the population is vaccinated. In this city, 5,000 people get COVID. 3,500 of these cases are amongst unvaccinated. 1,500 are amongst vaccinated. 200 people are hospitalized and 10 people die. In this city, or, this is a imaginary, fake, but the percentage of cases that occurred amongst fully vaccinated individuals is only 30%, because only half the population is vaccinated. 30% sounds better than 100%. So you would think, if you only saw this number, you would think, oh, this is better. But that's absolutely not correct. The scenario we want is over here. So this number on its own is very misleading. If you don't know the baseline vaccination rate, if you don't know how many absolute number of people got COVID, how many people got hospitalized, and how many people died, you have to have all of that information for this number to mean anything. Because if you have a situation where the entire population is vaccinated, every case is going to occur in a vaccinated person. But that's not necessarily a bad thing if nobody is ending up in the hospital. So this number on its own can be a little bit misleading, and you have to put it into context of these other parameters. So in summary of the epidemiology, breakthrough infections in the era of Delta variant are definitely increasing. I think that's for sure. However, protection against severe disease, hospitalization, and deaths appears to remain robust, at least right now, in the beginning of September 2021. A booster dose of vaccination, at least here in the United States, is only recommended for patients with moderate to severe immunocompromising conditions, such as cancer, organ or stem cell transplant, untreated HIV infection, active chemotherapy, and taking immunomodulatory drugs. Of course, we need to have continued close monitoring and vigilance. This will be important to detect future epidemiologic changes, but this is the sort of current summary based on where we are right now. Okay, let me shift gears now to talk about treatment. And some of it will be review, but I hope to also update some new studies that have come out recently. First, I only have one slide on this because I don't have enough time to go over every single study. That would take a long time. But let me just suffice it to say, all these agents on the right, on the left, have not really been proven in any prospective, well-designed prospective randomized controlled trial to have benefit in prevention or treatment of COVID-19. And we can go through all the details of this, if anybody wants, but But bottom line is they either have negative studies or poorly done studies or no studies. And those include hydroxychloroquine, azithromycin, doxycycline, ivermectin, which I know has been in the news a lot, especially here in the United States. But really all the studies that have been done so far are either very poor methodology and are not conclusive. Just for your knowledge, there are 3 or 4 prospective randomized controlled trials going on of ivermectin here in the United States. Actually, they're going on. So I wouldn't say the story is closed on ivermectin, but right now, we don't have any good solid evidence to support it. Convalescent plasma, vitamin D, zinc, aspirin, and 2DG. None of these really have good evidence right now for prevention or treatment of COVID. Maybe some of that will change in the future. For example, if a good randomized controlled trial shows benefit from ivermectin, we can think about it then. But right now, we don't have that. Let me talk about post-exposure prophylaxis for COVID, meaning somebody is around somebody else who has COVID, and now they themselves don't have COVID, but let's say their family member or somebody else had COVID. Can they take anything to prevent developing COVID after this exposure? And this has been a recent update within the past couple of months. We didn't have this previously in the United States. This was a very nice article published in the New England Journal, I think at the beginning of August of just 1 month back. And it was Regeneron combination, casirivimab plus imdevimab, monoclonal antibody therapy for prevention of COVID-19, meaning somebody had been exposed to COVID. Now, could we prevent it from developing COVID? And in the interest of time, I'm not going to go into the details of this study. It was an excellent study. And on the basis of this study, on July 30th, 2021, the United States FDA granted emergency use authorization for Regeneron to be used as post-exposure prophylaxis for patients who are at high risk of progression to severe COVID, who are either not fully vaccinated or are immunocompromised. So if somebody is at high risk for progression because they're older, they have diabetes, they have cardiovascular disease, they have obesity, whatever reason, and they're either not fully vaccinated or are immunocompromised, then they will benefit from getting Regeneron after being exposed to COVID. And I'm sure many people know this, but just by way of reminder, a monoclonal antibody is one specific type of antibody that targets one particular epitope or one particular antigen on the surface of the virus. A monoclonal antibody cocktail, which is what Regeneron is, it's a combination of 2 different types of monoclonal antibodies, as you see here, and they target 2 different antigens on the surface of the virus. This is in contrast to polyclonal antibodies, which is what's in convalescent plasma, which is a whole bunch of different types of antibodies. That's why we call it polyclonal. But anyway, I thought this was a nice picture to help demonstrate that and just remind us, what it is that we're talking about. Before we go a little bit further into treatment, I just wanted to spend a couple of slides to review the severity classifications of COVID-19. And the reason I'm reviewing it is because how severe somebody's COVID infection is directly relates to what therapy we should be giving them. Meaning if they're asymptomatic, they're not going to need anything. If they are severe or critical, they're going to need more. So I thought it would be helpful to briefly review this. I know I've reviewed it in the past, but every time I think it's useful to go over it briefly because the treatments only make sense in the context of illness severity. So the categories of severity of illness of COVID-19 are asymptomatic, mild, moderate, severe, and critical. So for asymptomatic COVID-19, there's no treatment. Basically, if somebody has COVID and they feel fine, they feel nothing, there's not really any treatment for such a patient. The main thing is just, keep them isolated and try to monitor for development of any symptoms. Mild COVID-19 is any single sign or symptom of COVID that does not include shortness of breath, because that implies potentially lower respiratory tract disease. If somebody has a chest X-ray, it should be normal. Moderate COVID-19 is any evidence of lower respiratory tract disease. either by clinical assessment, meaning the patient has shortness of breath, or you hear some creps or crackles or rows or something like that on your auscultation, or by imaging if it's available. And if you have an oxygen saturation, it should be greater than or equal to 94 while the patient's on ambient air for it to be moderate. Severe COVID-19 is any one of the following. The patient is breathing very quickly. The oxygen saturation is less than 93%. And if the patient's on chronic oxygen therapy, there should be a decrease of at least more than 4% from their baseline. So for example, somebody with COPD or interstitial lung disease or some other condition like that. Their PF ratio, PaO2 over FiO2 should be less than 300, or on imaging, lung infiltrates should be more than 50%. If anybody has any one of these criteria, then they're classified as severe. Critical disease is any one of the following: respiratory failure, septic shock, or multi-organ dysfunction. So as I mentioned, the management of asymptomatic COVID is nothing. Basically, isolate the patient, monitor for development of symptoms. There's no treatment. For mild to moderate COVID, currently in the United States, there's no oral treatment that's authorized for outpatients with COVID. I know people get a lot of different things prescribed to them by their physicians or others, but currently there's no oral treatment that's authorized in the United States for outpatients with mild to moderate COVID. Now, what does have mortality benefit is monoclonal antibody therapy for patients who are at high risk for progressing to severe COVID. And so who's at high risk for progressing? Again, older people, people who have diabetes, cardiovascular disease, obesity. Obesity is a major risk factor, actually. And kidney disease, or any number of chronic medical conditions put people at high risk for progression to severe COVID. In that case, monoclonal antibody therapy does have mortality benefit for patients with mild to moderate COVID. So what are the three main options? They are bamlanivimab and etesevimab. I'll mention, that's a product made by Eli Lilly. I'll mention that in late June of 2021, actually distribution of this combination was stopped because it lacked efficacy against the variants. So we're not really using it much in the United States. The main one we're using is casirivimab plus imdevimab, which is Regeneron. And then finally, there's actually another one that has emergency use authorization. It's called sotrovimab, but we don't use it much in the United States. There are a few places that use it, but actually mostly in the United States, we're using this second drug, Regeneron. In terms of management of severe COVID-19, remember that the severe definition includes an oxygen saturation of less than or equal to 93% while the patient's breathing ambient air if they're not on chronic oxygen therapy. The main treatment in this situation is still dexamethasone. That's an old-fashioned drug. It's been around for a long time. It's a steroid. It's cheap. It's easy to take. It's once a day. It can be oral. Dexamethasone is still very, very effective and is still our best treatment for patients with COVID in the hospital. I know we have a lot of different treatments, but still dexamethasone is probably our best treatment. And if the patient is going home before 10 days, they can actually probably be stopped. The dexamethasone can be stopped. The reason for that is the way that the original trial was designed, the recovery trial. The protocol was they stopped dexamethasone when the patient went home, left the hospital, even if it was before 10 days. You can also give remdesivir for 5 days. You can maybe or maybe not. Honestly, the World Health Organization doesn't even recommend remdesivir anymore. So you can use it if you want. It's probably not going to hurt. But the most important is dexamethasone. If the patient is critically ill with COVID, then still our main therapy is dexamethasone for 10 days. And these are usually patients in the ICU. As I say, you can consider remdesivir, but there's no strong mortality benefit in the ICU setting. Okay, I want to talk a little bit about two drugs that are a little bit new. One is tocilizumab, and the other one is Bearcytonin. Tocilizumab is an anti-IL-6 receptor antibody, and it received emergency use authorization from FDA on June 24th, 2021. There were 5 studies published towards the end of 2020 and the beginning of 2021 that showed no mortality benefit from tocilizumab. In fact, 5 very, very good studies. Some of them were done at my institution, Baylor. And they were very good studies, but they didn't show any benefit from tocilizumab. The problem was that they were probably giving it too late. They were giving it to the patients when they were in the ICU for maybe a few days. And by that time, they were already so sick, it's not going to make a difference probably. And so I think they didn't detect a signal because it was just too late already. The patients were too sick. But since then, there have been 2 major trials that have shown significant mortality benefit from tocilizumab. And the advantage of these 2 trials is that they gave tocilizumab earlier in the course. They didn't wait until the patient is in the ICU. They're usually giving it to a patient who's on the regular ward, who's getting a little bit worse. That's probably a good patient to give tocilizumab. You also don't need to give it to patients who are at home. Mild COVID. I don't think that it's not needed in that situation. Best is patients who are in the hospital, getting a little bit worse, but not necessarily yet in the ICU. So the first trial that showed some benefit from tocilizumab, again, mortality benefit, was called REMAP-CAP. REMAP-CAP had a total of 865 patients, half of whom received tocilizumab or another anti-IL-6 inhibitor called cerulumab. And importantly, 80% of these patients were on steroids. So tocilizumab was given on top of dexamethasone. Again, dexamethasone is the most important, but tocilizumab was given on top of that. And only about 1/3 of the patients actually got remdesivir. The inclusion criteria were, for this study, the patients had to be admitted to the ICU, but they were enrolled within 1 day of going to the ICU. So they went to the ICU and immediately they gave the patients a dose of tocilizumab. Rather, they didn't wait until 5 days later and then give them tocilizumab. They gave it to the patient just when they got to the ICU. And the patients should have been receiving some kind of respiratory or cardiac support. Respiratory support could have included invasive or non-invasive ventilation, including high-flow nasal cannula. Cardiac support was any kind of IV infusion of a pressor or inotrope. Exclusion criteria were presumed imminent death, pregnancy, elevated liver enzymes, or thrombocytopenia. And I'm not going to go into details of this. This is their major sort of figure that shows mortality benefit. You can go to the whole paper if you want to read it. But anyway, suffice it to say, they did have mortality benefit from giving tocilizumab with these criteria. The second study that showed a lot of benefit from tocilizumab is the same recovery trial. Recovery trial, by the way, is probably the best trial in the world right now on COVID-19. Recovery trial established the benefit of dexamethasone. Recovery trial has established lack of benefit of a lot of drugs. Recovery trial also established the benefit of tocilizumab. So they've really been one of the best trials in the world is the recovery trial, which is conducted in the United Kingdom, UK. So the recovery trial had 4,000 patients. 2,000 of them received tocilizumab. The other 2,000 received normal. 80% of the patients were receiving steroids. So importantly, again, they were getting the most important treatment, which is dexamethasone. Inclusion criteria in this trial was oxygen saturation less than 92%, or the patient was receiving any supplemental oxygen, even just simple nasal cannula. Importantly, though, the patient's CRP should be more than 7.5. And in some places, it's 7.5 milligrams per deciliter. In some places, it's 75 milligrams per liter. So it just depends what are the units, whether 7.5 or 75. But anyway, the point is the inclusion criteria were the patients were a little bit less sick. They were still sick because they were in the hospital and they were hypoxemic and they had elevated inflammatory markers, but they usually were not in the ICU. The exclusion criteria were any other active infection. And again, they show a mortality benefit from tocilizumab in this trial. So on the basis of these 2 trials, tocilizumab received emergency use authorization in the United States and is recommended for hospitalized patients on some oxygen who are getting worse. It's recommended by the Infectious Disease Society of America and National Institutes of Health, both. And this is a graph that shows a kind of a meta-analysis of all the studies. So if you see all the prior studies didn't really show any benefit in any direction of tocilizumab. But then if you look here, this big square is the recovery trial. And it shows that it's in the direction of tocilizumab being better. And again, the benefit of this trial was that they had 4,000 patients, so very well powered, number one. Number two, they gave tocilizumab earlier. So that's, I think, why it was successful. Let me switch gears to another newer agent called Bearcytonin. Bearcytonin is a Janus kinase or JAK inhibitor. This received emergency use authorization from United States FDA to be used independently on July 28th of last year. So about 6 weeks ago, 8 weeks ago, it received authorization. So here's the main, here are some of the old studies on Bearcytonin and how things have changed over time. So first, there was something called the Act 2 trial. This was published in December in New England Journal. It was a trial of remdesivir plus Bearcytonin versus remdesivir plus placebo. A trial of 1,000 patients did not show mortality benefit for remdesivir plus Bearcytonin. And in fact, only 20% of the patients were receiving steroids. So I didn't think it was a very positive trial. And yeah, I sort of put it out of my mind. But I thought it was overall a negative trial. Subsequently, there was another trial called Act 4. This trial was supposed to be remdesivir plus dexamethasone versus remdesivir plus Bearcytonin. In April of this year, in fact, this trial was stopped. They stopped enrollment because of futility, meaning they had enrolled so many patients, they saw no difference in outcomes, so they stopped the trial because it was going to be negative. So after these two trials, in my mind, Bearcytonin had gone away. I was not using it on any patients, in fact, because I thought I saw these two trials. Okay, it's not doing anything. There's not much benefit. Why bother? But subsequently, and very, very importantly, and this is brand new. You may or may not have seen it already. This trial called Covet was published just within the last 2 weeks, published in Lancet Respiratory Medicine. Efficacy and safety of Bearcytonin for the treatment of hospitalized patients with COVID-19. Brand new trial published in last 2 weeks. It's called Covet, published in Lancet Respiratory Medicine on 1st September, so 10 days ago. This is a trial of 1,500 hospitalized adults. Half of them received Bearcytonin, half of them received standard of care. Inclusion criteria were the following: active symptomatic COVID requiring any supplemental oxygen, and at least one elevated inflammatory marker, CRP, D-dimer, LDH, ferritin. Again, these are all hospitalized patients. Exclusion criteria were the following: anybody who was intubated, already receiving some other immunosuppressive therapy, or prior receipt of convalescent plasma. Importantly, 80% of the patients were receiving corticosteroids. So again, the backbone therapy for severe and critical COVID is still dexamethasone. But 80% of the patients were receiving the appropriate backbone therapy, which is steroids. Only a fifth of the patients, 20%, were receiving remdesivir. And the adverse events were similar between the two groups. You usually give Bearcytonin is an oral drug, by the way, it's PO. The usual duration is 14 days, 2 weeks, or until the patient is discharged from the hospital. You can stop it if the patient is discharged. And they show a mortality benefit in the group of patients who got Bearcytonin. Large trial, 1,500 patients, well designed. The patients were getting the appropriate standard of care. Excellent study, published in a very good journal. And they show mortality benefit from Bearcytonin. So it was on the basis of this trial that US FDA gave emergency use authorization for Bearcytonin. And it's recommended by the Infectious Disease Society of America and National Institutes of Health. So the question I always get now, the standard question I get is: patient comes to the hospital. They're on 5 liters of oxygen. They're getting dexamethasone and remdesivir. They're getting a little bit worse. Next day, they're on 10 liters. Immediately, the question always I get is, should I give the patient tocilizumab or should I give the patient Bearcytonin? How do you decide which one should you pick? And the answer to that question is, we don't know. That's the honest answer, is we don't know that which one is better, because all the trials have been done in parallel. So patients were getting steroids and they got placebo or tocilizumab. Patients were getting steroids, they got placebo or Bearcytonin. But there's no trial as I've shown on the slide here, this is where we have gaps in knowledge. We have no randomized controlled data to know which one is better, dexamethasone plus baricitinib or dexamethasone plus tocilizumab. Nobody knows the answer to that question. Not one person in the world knows the answer to that question. Or remdesivir plus dexamethasone plus baricitinib or versus remdesivir plus dexamethasone plus tocilizumab. We just don't know. They are designing these trials. Actually, I think they're going to do them in the United States. But right now, we don't know the answer to this question. If the patient's getting worse, should you give them tocilizumab? Should you give them baricitinib? Some of it is dependent upon what are the patient's comorbidities? What can the patient take? So, for example, if they can't take pills, they can't get baricitinib because it's an oral agent. Conversely, maybe they can't get tocilizumab because they have a contraindication. Their platelets are 30, so they cannot get tocilizumab. So you can look at the exclusion criteria. But if the patient meets criteria for both, nobody knows which one is better at the current time. Let me show you a few other new trials, and then I'll close and take any questions that folks have. Here are a few other new trials you've made.
We can't hear you, Prateet.
Oh,
we
sorry,
can't hear you.
Can you hear me now?
We can hear you.
Oh, okay. Sorry. Can you, Dr. Kairam, you can hear me?
Oh, we pause now. Yeah, I can hear you now.
Okay, great. Here are some other new trials that have come out in the last 1 month or so. And so I thought you may be interested in them. And then, as I say, I'll close and I'm happy to take any questions. This is a trial actually not of direct treatment for COVID, but you may have seen it. It was published in the New England Journal in the beginning of August. And it was Empiric Therapeutic Anticoagulation for hospitalized patients who were not critically ill who had COVID. Let me just say, if somebody is in the ICU and is very sick with COVID, then now we have two very good trials that showed no benefit from empiric therapeutic anticoagulation, meaning the patient does not have documented venous thromboembolism, DVT or PE. They don't have that, but you're giving the patient therapeutic anticoagulation. If the patient's in the ICU setting, then we have two trials showing no benefit. This trial was very interesting. It was done in patients who were hospitalized, but not in the ICU. They're just on the floor in the general ward, but not in the ICU. So non-critically ill patients. And also, by the way, not at home, not patients at home, these are patients in the hospital. So this was a prospective randomized open label trial of hospitalized patients with COVID-19. Exclusion criteria were either vasopressor or inotropic support, meaning if they were on high flow nasal cannula, non-invasive ventilation like BiPAP or invasive mechanical ventilation, or all of these were also exclusion criteria. They were more than 3 days out from their admission. They were supposed to go home pretty soon. They had a high risk for bleeding. If they were on dual antiplatelet therapy, they were excluded. 2/3 of the patients were receiving oxygen via low flow nasal cannula or simple face mask. The primary endpoint of this study was organ support free days, meaning the patient didn't progress to high flow nasal cannula, non-invasive or invasive ventilation, or inotropic support. They had a total of 2,000 patients, or more than 2,000 patients, who were randomized to therapeutic or prophylactic dose anticoagulation. It was used for 14 days, or until the patient was discharged from the hospital, or until they were off oxygen for at least 1 day. And 2/3 of the patients were receiving dexamethasone in the background. And I'm not going to go over this table in detail. Let me draw your attention to the second row, which says survival without organ support at 28 days. And what you see here is that there's a 99% probability effect of therapeutic dose anticoagulation, meaning that there's a 99% chance that at 28 days, the patients will not have progressed to requiring organ support if they get empiric therapeutic anticoagulation. But again, remember, there were a lot of exclusion criteria, including high bleeding risk, dual antiplatelet therapy, a lot of other things. So you have to be very careful who you're going to choose to give therapeutic, empiric therapeutic anticoagulation. Let me also say that there's a row here for major bleeding. And the group of patients who got empiric therapeutic anticoagulation, they progressed less frequently, that's true. But they also had many more episodes of major bleeding. So you have to be very, very careful. And the authors estimate that for every 40 patients who would get some benefit from this, you have 7 episodes of major bleeding. So right now at our hospital and many hospitals, we're not routinely doing this for every single patient. We are picking and choosing very carefully which patients should get empiric therapeutic anticoagulation. Again, it shouldn't be patients in the ICU. We have 2 good negative studies. But for patients on the floor in the hospital on some amount of oxygen, I think it's something to think about, but you have to be very careful which patients you're going to select to do this. Finally, let me show you this trial, which has actually not been published in any journal. New England Journal, JAMA, Lancet, it hasn't been published yet. It's only published as a preprint trial. And as I showed you, monoclonal antibody therapy has benefit as post-exposure prophylaxis and for patients with mild to moderate COVID who are not that sick, but are at risk for progressing to severe COVID. That's where it has benefit. That's where it has proven benefit. Okay, so they did a very interesting study. Again, it's the same recovery trial in the United Kingdom. They did a very interesting study. For patients coming to the hospital, getting admitted to the hospital, at the moment of admission, they check the patient's blood for presence of antibodies against COVID. They check them to see if they're seropositive or seronegative, meaning they actually drew the patient's blood and checked a lab to see if they have antibodies. And then they showed this data, which is very, very good. It's very interesting. Seronegative versus seropositive patients. And they give the patients, they gave half the patients monoclonal antibody therapy or half the patients usual care. And let me draw your attention here to these top 2 lines. These are patients who are seronegative at the time of admission to the hospital, meaning at the time they got into the hospital, they did not have antibodies against COVID. And if those patients got Regeneron, monoclonal antibody therapy, even in the hospital, they had significant mortality benefit compared to usual care. If the patients were seropositive, meaning they had antibodies already, there was no difference. So the key factor was, did the patients have pre-existing antibodies against COVID or not? Now, a couple of caveats here. First, this is a preprint study. It has not been published in any journal yet, number 1. So it hasn't been peer reviewed. Number 2, in the United States right now, we have no emergency use authorization for this purpose. And number 3, it hasn't yet been officially recommended by the Infectious Disease Society of America or National Institutes of Health. So right now, I thought there was an interesting study. You can find it on the internet. And I think it's going to get published soon. My guess is it'll get published in New England Journal. I'm not 100% sure, but I think it's going to get published soon. And I think it's very interesting. And I think it has the potential to change the standard of care, which is that when you come to the hospital, you get antibodies checked. And if they're negative, maybe you should get Regeneron. But again, right now, we don't have emergency use authorization for this purpose, and it's not yet recommended specifically. So, for example, at our hospital and many hospitals, it's not being done currently because this trial hasn't been officially published yet. Finally, I get a lot of questions also about inhaled budesonide. And there were some prior studies about inhaled budesonide for mild, moderate COVID at home, meaning somebody had COVID at home. Should we give them an inhaled corticosteroids to help them recover more quickly? So this was a trial called the Principal trial in the United Kingdom, published in Lancet in August, so 1 month ago. And let me back up a second. It was a trial of older population. Everybody was above the age of 50. And they all had mild, moderate COVID at home. So they were not in the hospital, but so they were mild, moderate COVID at home. And the question they asked is, if you give them inhaled budesonide versus nothing, versus standard of care, which is nothing, then do they have some benefit? And their primary endpoint was time to recovery. And it was a pretty good trial. They had 787 patients who got inhaled budesonide. They had 1,000 patients who got usual care. And here's what they show, that the time to recovery for patients who got inhaled budesonide was about 12 days. And the time to recovery for patients who got usual care was about 14.7 days. And so the difference in time to recovery was about 3 days. So, and it was statistically significant. So patients who got inhaled budesonide, they recovered more quickly. Again, you can decide whether 3 days is significant or not. Statistically, it was significant. From a practical standpoint, is there a big difference between 11 days and 14 days? Maybe, maybe not. I guess, yeah, it depends how important that is. For me, actually, that's not very important. Is there a big difference between 11 and 14? No, it meets statistical significance, but is it clinically relevant? Maybe, maybe not. Depends on your, somebody's opinion. Their other outcome was hospital admission or death at 28 days. And in the group that got inhaled budesonide, that occurred 6.8% of the time. In the group that got usual care, that occurred 8.8% of the time. So that, now you can say, well, now that seems significant because at 1 month, the group that's getting inhaled budesonide, they're getting hospitalized less or dying less. So that's a more firm outcome. And you can say, well, that looks pretty good. But let me show you the details of that because they combine the outcomes, hospitalized and death. They combined them into one outcome. They didn't separate them, but in a subsequent table, you can see the separation. And if you go down to the row that shows death, in the group that got budesonide, there were only 6 deaths. In the group that got standard of care, there were 10 deaths. So this is hardly any difference. It's 1% in both groups. So to me, that's not dramatically having any mortality benefit. There were some, less people who got hospitalized. But even if you look at, the number of percent of people not admitted to the hospital, it's 91% in the inhaled budesonide group. And in the usual care group, it's 88%. So, I don't see much difference here, especially there's not much difference in death, which is the most important outcome. So some people are looking at this and think it's pretty significant. I don't know. To me, it's a judgment call. And again, this trial was done in patients who are older than age 50 or older than age 60. So for a young, healthy population, that's not even who was studied in this trial. So for me, this is not a dramatically significant trial, but it's something to think about in a patient who's above the age of 50 or 60. So in summary of treatment, post-exposure prophylaxis should be given to unvaccinated or immunocompromised patients and they should get monoclonal antibody therapy. It does have mortality benefit. Asymptomatic COVID, there's no treatment, still no drug that we can give, and the treatment is just monitoring. Patients with mild to moderate COVID who are at high risk of progression to severe disease should get monoclonal antibody therapy if it's available. For patients who have severe or critical COVID, main treatment is still dexamethasone. You can consider remdesivir. And depending on the details of the case, especially if the patient's getting a little bit worse, you should think about tocilizumab or bearcytonin. There's no head-to-head trial. I think that will come eventually. But if the patient's getting a little bit worse and they're in the hospital, I would seriously consider to give them tocilizumab 1 dose or bearcytonin oral. And then finally, you can consider empiric therapeutic anticoagulation for patients who are not critically ill, meaning not in the ICU, but they're in the hospital, assuming they have no major exclusion criteria. I think it's something to think about. I should say, I discussed this with many of our hematology colleagues at my institution. Most of them were not in favor, actually, of doing it. So let me just tell you that. I looked at it. I think for some patients, you can think about it. But in the hematology world, at least in my institution, nobody was that favorable. I should add, I checked the recommendation from the American Society of Hematology for this question. They haven't yet given a recommendation. So they themselves are still analyzing this paper, and they haven't given a firm recommendation about what to do. So I think the jury is open on empiric therapeutic anticoagulation for non-critically ill patients. So let me stop there, and I'm happy to take any questions, Dr. Kairam.
Thank you very much. once again, you gave tremendous amount of detail, direct treatment recommendations supported by evidence. Thank you for the attention to detail. Knowing that we would have at least 25-30 minutes for asking questions, I had asked Dr. Chilamuri at the end of his talk, come up with 1 or 2 questions that required to be answered for the general audience. So Dr. Chilamuri first.
No, I'll go last. You can let me go through the chat questions so you could answer them. I think you covered advice on booster dose, but maybe you just want to repeat that.
Sure. At least in the United States right now, booster dose is recommended only for people who are moderate to severely immunocompromised. That includes the following: people receiving chemotherapy, people who have gotten organ transplant or stem cell transplant, people with untreated HIV/AIDS infection, or people receiving immunomodulatory therapy for rheumatologic conditions, such as high-dose steroids, TNF-alpha inhibitors, variety of other immunomodulatory agents. There's no general recommendation for everybody to get a booster right now, including even elderly population. I suspect that may come actually maybe in 1 month or so. We may get a recommendation, especially for older population, meaning maybe above age 65, something like that, should get a booster. Right now, we don't have that specific recommendation. So right now it's only for moderate to severely immunocompromised patients.
And the next one is, what should be come to United States as a traveler? What are all the requirements right now if a foreigner wants to visit? Let's take from India. So they have 3 different vaccines. So which vaccine is obviously recognized by the CDC? I think that would be the first aspect. And then what else should they do before they come?
Yeah, so the main thing is, of course, to get vaccinated. I think, if I'm not mistaken, I think they will accept if somebody has Covishield or Covaxin. I mean, I would have to double check CDC's website, but I think they will.
They'll accept AstraZeneca.
Right. And then the other main thing is to have a negative COVID test, within a few days before you travel.
72 hours.
Yeah, that's the most important component. I think that they would request.
Yeah, I agree. It's 72 hours before you come, you need to get a test. It could be PCR, it could be rapid antigen. So that's different from other countries. So they will accept a rapid antigen. And then you should be, AstraZeneca is the vaccine they'll accept from India. I think they now accept the other one too. That's, you just need to check on the CDC. And after you come to United States, 4 days after you come here, you have to do another PCR test. Right. So that's the other thing you have to do upon arrival to the United. How would you treat fatigue in a long COVID patient?
Yeah, great question. As Dr. Kairam mentioned at the beginning, I'm the director of our long COVID clinic at our hospital. So I've seen, more than 100 of these patients. The short answer is we don't know for sure. There's no randomized control trial of therapy that's been published for long COVID fatigue. So one option is you can just try something, but as this group has probably figured out by now, I try to stick to the evidence. So I haven't really done that in my patients. What I have done is I do try to rule out any other diagnosable, reversible causes, meaning I do full workup for anemia, hypothyroidism, sometimes even adrenal insufficiency, vitamin B12 deficiency, things that I think objectively can cause somebody to have fatigue, or even things like obstructive sleep apnea or other psychiatric concerns. Anything that I think could be treated, I try to evaluate those fully. If I find something, and sometimes I find things, I find like, I found one patient with adrenal insufficiency. I found one patient with hypothyroidism. So sometimes I find things. If I find them, then I treat that. If I don't find anything, I don't like to just give the patient some random treatment. Instead, I try to counsel them and I try to give them some advice that, okay, hopefully this should get better in the next few months. The other thing that I do think may help, again, we don't have a randomized controlled trial, but I don't think it'll hurt, is some kind of rehabilitation, either cardiopulmonary rehabilitation, exercise tolerance, some kind of thing where they can slowly increase their endurance. I would try that. I suspect it won't hurt. But again, we don't actually have a trial showing that it does anything. But I would prefer that rather than some pharmacological, like giving them a pill, then they have some side effects and some other problems. So I'm trying to avoid that. And we really don't have any evidence. So I guess my summary is I try to counsel the patient, work up any organic causes of fatigue, like diagnosable and treatable, and then potentially refer them for rehabilitation, if I think it could be helpful.
Sure. Can you comment on furin blockers in early infected state?
Yeah, I mean, I think there have been some in vitro studies on that. But again, I would wait for randomized controlled trials in actual patients, because I think our best example of that not working out is hydroxychloroquine, which had great, I mean, the in vitro data for hydroxychloroquine is excellent, actually. It's very good. And that's why, many people were giving it, including at my institute. I mean, a lot of people were giving it. But ultimately, it was shown not really to have benefit, and other things have benefit. To my knowledge, we don't have any prospective randomized control trial. I think it's mostly in vitro data currently.
Yeah, Comestat is one of them. It's done only in cell lines, never done in humans yet. I agree. Long COVID pain and fatigue, and is there any evidence for autonomic dysregulation as a common denominator?
Yeah, good question. I've seen some reports about autonomic or dysautonomia as a potential contributor. I think we're still learning about long COVID. I don't think we have the final story on long COVID. Some people have drawn a comparison between long COVID and so-called myalgic encephalitis, chronic fatigue syndrome, ME/CFS, which is a condition I didn't know much about, but it has a lot of features which are similar to long COVID, including significant fatigue, post-exertional malaise, unrefreshing sleep, and dysautonomia is one of the features of that condition. So it may be that long COVID is going to end up being similar to myalgic encephalitis, chronic fatigue syndrome. Maybe, maybe not. I'm not 100% sure. So I think it is a feature, but out of the patients I've seen, some of them have it, but not necessarily all of them. So I would view it as some people may have it. It may have some overlap with ME/CFS, but I think the jury is still out on that question. And exactly how much of a contributor it is, I don't think we 100% know.
Any comparative studies between Decadron and Solumedrol? Is the one steroid better than other?
Not to my knowledge. I mean, that's a good question. I mean, I guess all of our hospitals default to using Decadron, dexamethasone, because that's what was used in the study. So I'm not sure of a head-to-head comparison study. If there is one, I may have missed it, but to my knowledge, I haven't seen it. Most of the studies say, most of the recommendations say, if you have dexamethasone, just use it. If for some reason you don't have it, then give an equivalent dose of Solumedrol, which is fine. But if you have a preference, I think the preference would be dexamethasone. Does it really make a difference? Maybe not, but we have a trial for dexamethasone. So if you have it, might as well use it. Dexamethasone is pretty cheap. I think the only reason not to use it is if for some reason the hospital ran out, then you can use something else. But it's pretty cheap drug. It's not too expensive.
Yeah, so there's one trial in Iran by there's an ID person from MGH who's originally from Iran, and he did these studies and he did a good study. And as you said, at the end of the day, it didn't seem to matter which one you use. Yeah. I think somebody commented proprioceptive input error perhaps explain the common feature, I guess, about fatigue and pain maybe. Let me keep moving.
Yeah, let me pick up on that one.
Yeah.
When you were mentioning myalgic encephalomyelitis, previous name chronic fatigue syndrome, this disease for about 25, 28 years has been looking for an etiology. No one has ever found it. It's a disabling condition for the sufferer. 15 years ago, 14 years ago, there was a brief excitement that it is being caused by MERS. It did not last. So several laboratories got excited, but I wanted to raise that with regard to your answer about fatigue. The fatigue that comes following chikungunya or dengue recovered or this disease is all the same fatigue. So I don't think there is as yet any explanation whether it is neurogenic, neuromuscular junction, myopathic, or neuritic, but does not appear to be from the brain. In the sense, if you get that person into an aggressive rehab, exercise, you might be able to address the fatigue. But at this moment, from what I'm eagerly looking for data on long COVID neurology, there doesn't seem to be much guidance. Now, a sister condition is POTS, postural orthostatic hypotension tachycardia. There again, the finger is pointing at not autonomic dysfunction. So it would not be surprised if there is an autonomic neuropathy, but clearly there is not enough data. The NIH has embarked on a gigantic post-COVID neurology study. It may not be another 18 or 24 months we would have enough data. In the meantime, all the Indians are giving vegetarian diet. They think that will help. They're also practicing yoga. Definitely it might help. Breathing exercises probably will do a great job, but exercise. That's what I have been learning.
I think I just want to comment since you said, I think Prateek said it. Firstly, I want to say that no two patients are alike. So when you look fatigue and put it in one basket, you will make a mistake. So in some we see fatigue because they have sleep deprivation. So he pointed out about obstructive sleep apnea. You may want to do sleep studies in some people. In some, we see actually myositis. So we will see significant elevations in CPK with even the presence of ANA, and they actually respond to either steroids or immunoglobulins. So that's a different kind of fatigue. And then the third group with the sleep various pain syndromes, and the pain is keeping them awake, and that causes the fatigue, and in which case you may have to treat pain aggressively, particularly using gabapentin or something like that. So I just want to, as you see these patients, I think you pointed out rightly, do a thorough workup. Don't put all in one basket. Each may have a different etiology, and it probably will end up being multiple etiologies, and you may have to individualize therapy for a given patient. I think that would be the best approach until we get better data. But I think we'll never get that data because there are a very disparate group of patients which we're trying to put into one basket called the long COVID. I don't think that's one disease. It's multiple syndromes that we're calling it into one basket and probably making a mistake there. Let me keep going. Is vaccination certificate required to enter US? Yes, your airline will ask you to show a valid, fully vaccinated certificate before you can enter. So that's how they know you got vaccinated. So they would like to see it. You know, sometimes they question the validity of these vaccine certificates. So make sure you have a decent, good official one. What's the treatment for decreased sleep in long COVID patients? Anyone wants to answer?
Yeah, I mean, I think all the things that we've been talking about, you know, maybe consider a sleep study, for example. To me, that's the most objective way. And the most common diagnosis would be sleep apnea, but maybe some other parasomnia or something like that can be diagnosed. So that's what I would go for. Yeah, otherwise hard to know. As Dr. Kairam said, exercise, rehabilitation. I think, I mean, yeah, I mean, to me, those are the main common sense, normal things to do.
Yeah.
When I would hesitate,
and pranayama.
Yeah, that's never going to hurt, obviously, yoga and things. What I wouldn't do is, you know, and sometimes it happens in the United States also, is, well, let me just give you, I don't know, venlafaxine or gabapentin, or let me just try, you can do that. The problem is you don't actually know if it's doing anything, or the patient would just get better on their own. And it can have side effects potentially and make the situation worse. So I guess my approach has not been to do that until we get at least some data about what may work.
I have one comment. Most of these people who have fatigue, enough fatigue into 1 month, 2 months, 3 months, also have significant weight loss. First, you have to feed them, get weight. And as Dr. Martanda Sastry pointed out, yoga and pranayama probably have as much evidence as all the other things. So do everything. In other words, I don't think there is any guidance. And as Dr. Shilimuri said, it could be from many, many things. Acutely, if you have elevated CPK, that's unlikely 2.5, 3 months into it. Acutely, you will address that. So, but I think we don't know enough about the cause of long fatigue, 3, 4, 5 months. There are anecdotal cases of terrible outcome. I do want to take you back quickly. There has been a question in the chat box from my—
I'm going to the questions. What is the impact of baricitinib on IL-6 levels? Do you actually do levels after you give medications?
Not really. I mean, I'll just be honest. Not really. Usually, we use it up. Yeah, we use it up front to help decide, how much inflammation does the patient have. And then if you think, okay, I'm going to give tocilizumab, I'm going to give baricitinib, you can go ahead and start it, give it, and then just follow the patient clinically. What is the oxygenation status? Are they getting better? Are they getting worse? And let's say, okay, for example, let's say 3 days later, the patient's oxygen requirement has gone down, everything's going better, they are, more awake, everything. Now the IL-6 level went up slightly. I probably wouldn't do anything different in that situation if the patient is clinically better. So I think establishing a baseline is helpful. Maybe for research purposes, these kind of things could be helpful. But I think from a clinical standpoint, actually seeing the patient, I don't know if it makes much of a difference after 1 week or 2 weeks.
Yeah, we do not use IL-6 levels to guide therapy at all, whether to initiate therapy or, for that matter, to see if it's responding to you. What we do, what we're looking for is macrophage activation syndromes. For us, we use ferritin as the measure. If the ferritin is getting to be really high, we think that's and after you started Bexa, and you're not seeing the levels coming down or instead rising, we would call that macrophage activation and then start either tocilizumab or baricitinib.
Yeah.
We've used anakinra also.
Yeah, and so there was actually, just to let you know about anakinra, there was a study on anakinra, which is an anti-IL-1 antibody. It's called canakinumab. There was actually a study published. It was a negative trial. It didn't help. So, we haven't been using it much because of that negative trial. So I agree with you. Ferritin was actually used in the baricitinib trial. So it was one of their markers. The other one that I think is very helpful is CRP, C-reactive protein, because CRP was used in the baricitinib trial. It was also used in the recovery trial. So I think if I had to pick sort of couple to use, CRP and ferritin, I think are very helpful.
Again, the question on downloading a certificate to travel to US, I think the best information will come from the airline that you are flying. They will tell you exactly what they will accept. So it's not a government stipulated from the United States, it's your airline which decides how they will verify, because it's not the customs agents who checks it, it's the airline ticketing agent who will check if you have vaccine or not. So just to clarify that. Yeah, go ahead, Sudhakar, you can ask questions. I completed the chat.
Yeah. Thank you, Dr. Kulkarni. I have a question about the mucormycosis. What happened to the mucormycosis cases? We had an epidemic of mucormycosis for the previous 3 months. Now they've come significantly, they've come down significantly. Was there any cue as to what's the reason for that as you have seen over the period of time? Because so many things have been attributed to the causation of this particular problem. Was there any cue to what could have been the reason? and what could have been the reason not
Right. So I think the question was about mucormycosis. You know, what happened to the situation in India? The short answer, and I'm being very honest, is I don't know, and I don't think anybody knows 100%. But it definitely seemed related to the rise in COVID for sure. So I think there was something about COVID, contributing or predisposing. Again, I think the relevant question has been, why have we not seen that in the United States or in Europe or other areas which have had a big surge? I mean, even right now in the United States, we're having a big surge of COVID, but we're not having a big surge of mucormycosis. So I don't know the reason for why it went up and then even why it went down. There are a few possibilities. One is the weather. Two is the environment. Three is, we discussed before, maybe overuse of steroids, at least to some extent, maybe not all the patients, but some of them. Third is, prevalence of diabetes in India, although even in America, we have a fairly high prevalence of diabetes. So if that was the reason, I guess I would have expected more mucormycosis even here, because again, maybe India has even more, but we have a lot of diabetes in the United States. So again, I don't know 100% what was the reason, but it definitely seemed related to COVID, because as you saw, COVID cases have come way down in the United States. I mean, you know that in India, you know that better than me, actually. And mucor seems to have gone away. So there seems to have been some relationship with COVID. And so what provoked it in India, again, I'm not sure. It may have been a mixture of everything. I do think, at least to some extent, environment has some role, because Mucorales species is an environmental mold. It's sort of everywhere. So I do think environment probably played a role, or weather. But I don't know. The honest answer is I don't know 100%.
Okay. One other question that has been in the chat box for a while. Immunocompromised host exposed to COVID 11 days after the second dose of COVID vaccine. What is the role of Regeneron? When should it be given? Do you give it at all if the individual is only exposed but not symptomatic?
Yeah. So if the patient is immunocompromised, I would give it because even though they're fully vaccinated, if they're immunocompromised, then the idea is maybe they didn't mount a good immune response to the vaccine. So even if somebody's vaccinated, even if they're vaccinated, if they're immunocompromised, and again, moderate to severe immunocompromised, and they get exposed to COVID, I would just give them Regeneron, because the presumption is that maybe they didn't mount a good immune response to the vaccine. So I would give it for somebody who's immunocompromised, regardless of their vaccination status. If they have an exposure, if somebody, even in my hospital, if somebody asked me, I would give them Regeneron. Different if they were not immunocompromised, they were just somebody who's fully vaccinated and a totally normal immune system. In that case, I wouldn't give it.
This is an immunocompromised one with
Yes.
renal transplant.
Yeah,
exposed.
I would give it. Yes,
But
absolutely.
When would you give it? As soon as the exposure?
As soon as possible after the exposure. I would just try to give it.
Okay. Before I drop those questions, Dr. Naveen put in a comment. I don't know if it is a problem with spelling. Is there a drug called Regeneron?
What?
You
No,
see,
that's the same thing. Regeneron. That's the
Regeneron. Oh, okay. Dr. Chilimuri, you answered the question regarding how do you get this vaccination certificate? Is that from the travel agency?
I said that they have to check with the airline. Airlines will tell you what they will accept, and that's what you have to provide.
Okay. Dr. Sudhakar, I think we have occupied Dr. Kulkarni enough.
Yeah.
And he's always so thorough and confident in his speeches.
Before we conclude, I would wish to make a small announcement here. Yeah, can I go ahead?
Yes, of course.
Yeah. So I have an appeal to all the listeners all those who have participated today, that there is a study being done by Dr. Kalpalata Guntupalli on burnout and gender, and I have already sent in many groups of the appeal that has been given by her, along with the link. There'll be a slight modification that will be done by her, and soon she'll be sharing the new link. And I'll be sharing the same link to each one of you. And please go through that and spend some 10 minutes time to answer that. It will be a good study. And this is a request from Dr. Guntupalli. And I'm sure you'll all spare some 10 minutes time to answer the questionnaire. So with that announcement, I wish to thank Dr. Kulkarni for such an elaborate presentation and to the point and the evidence-based. And I also thank Dr. Sridhar Chilumuri for answering all those questions in the chat box, for taking the chat box forward. And my special thanks to you, Dr. Kairam, for making this possible and finding us good speakers who are the need of the hour, and particularly dealing with the situation as and when we get new problems that are being faced by us day in and day out. I'm sure that with weeks to come, we'll have more speakers who will be addressing the current scenario, both in India as well as in the United States of America. And thank you all. Thank you. Before I conclude, the last word from Dr. Kairam.
Quick comment. Dr. Kulkarni was found for us through Dr. Guntupalli.
Yeah.
I have some experience with surveys sent to people like this. Most people don't respond. I have a serious, sincere appeal. When you get that survey from Dr. Guntupalli over the next few days, please respond. We owe it to her. I believe she herself is involved in this survey that they are doing, having experienced tremendous psychological stress in the last year and a half about stress and gender. So please pay attention when you receive that, fill it out, do the survey online, and I want to make her happy. Thank you very much. Thank you, Sridhar. Good night.
Thank you all. And Dr. Kairam, I will share the slides with you. Please feel free to distribute them to everybody.
Yes, we will do that. Also, this lecture is available on the Andhra Medical College YouTube.
Great. Thank you again, Dr. Sudhakar, Dr. Kairam, Dr. Chilumuri. Thank you all.
Thank you very much.
Thank you. Bye.
Thank you all.